Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friend. Welcome to this week's episode of the Healing Pain Podcast. I am your host, Dr. Joe Tatta. As always, it's a pleasure to be spending this time with you. This week, you will meet Dr. Lance Frank, a physical therapist that specializes in pelvic floor dysfunction in all gender identities. Dr. Frank opened his own practice shortly after graduating from the Doctor of Physical Therapy program at Emory University in Atlanta, Georgia. Lance is one of a small group of physical therapists that treat male pelvic floor disorders, and one of an even smaller group of queer practitioners that work in pelvic health. Lance understands people's awkwardness in the doctor's office discussing vulnerable issues surrounding their genitals. He also understands how toxic masculinity culture makes it difficult for men to discuss pelvic health and sexual dysfunction. In today's episode, we discuss various pelvic floor conditions such as male pelvic pain, erectile dysfunction, urinary dysfunction, prostatitis, and other sexual health concerns. Okay, without further ado, let's begin and learn about male pelvic health with Dr. Lance Frank. Hey there, Lance. Thanks for joining me this week.
Hey, Joe. Thanks for having me. I'm excited to be here.
Me too. I'm excited to talk about pelvic health in men. It's not an episode that I've recorded before. We've talked about women's pelvic health and women's pelvic pain, so I'm excited to kind of dive into this with you. It may be a new topic for some men who are listening. To hear the idea that there is pelvic health for men, and a lot of these conditions that we'll talk about can be effectively treated with pelvic health physical therapy. I think a good place to start is just give us kind of a overview of what the pelvic floor is and why it's important to men's health.
So when most people know that, well, whenever people hear pelvic floor or pelvic floor therapy, most people think, vaginas and postpartum, or maybe even menopause with prolapse. But aside for two very specific urinary muscles in the vagina versus the penis, all of the muscles in the pelvic floor are exactly the same. They're just oriented a little differently. And they all have the same functions, urination, bowel movements. They play a role in sexual function and intimacy. And then they also just play an overall supportive role. They sit inside the pelvis, kind of like a hammock or a trampoline. They just kind of hold everything in place. In terms of the deepest layer, the external layers are the ones that form the genitalia. Those are the ones that their orientation differs between the genders. And somebody with a penis, those muscles in the clinic, I call them the banana peel muscles, because if you look at an anatomy app or a model, they kind of wrap around the shaft of the penis where they come out underneath the pubic bone, similar to the way a banana peel kind of wraps around a banana. And so whenever I'm talking about erections or urination with my patients, I usually refer them to the banana peel muscles. But aside for their orientation, all of those muscles are essentially the same in somebody with a vagina, and they have all the same functions.
So essentially, the male pelvic floor and the female pelvic floor is the same.
Correct. The muscles on the outside wrap around the vaginal canal and create a literal canal. But somebody with a penis, like I said, they wrap around the entire thing and they form the shaft of the penis. They don't go all the way up. They stop about halfway up the shaft of the penis. But yeah, the orientation is just a little different, but functionality is exactly the same.
And you mentioned a supportive role of these muscles. Tell us what they're supporting.
Yeah, I mean, they support a lot of things, but they are the connection between basically our upper body and lower body. And all of the intra-abdominal organs sit directly on top of them. The bladder, the prostate, the liver, the large intestine, they all sit in this hammock that the pelvic floor muscles form. Not only do they have a visceral support system, but they also connect all of the bony systems, the pelvis and the SI joints and the hip rotators. Like they support the body both, like I said, from that visceral standpoint, but also from an orthopedic standpoint. A lot of people with SI joint pain or low back pain or lateral hip pain may come in presenting with, it may seem like a torn labrum, or it may just seem like SI joint dysfunction, but it could be coming from the pelvic floor. And so when we're talking about what all the pelvic floor supports, it's got this huge network of attachments that it plays. They hold everything together. The upper body and the lower half, the hips, they kind of hold, they're the glue that holds everything together.
And then I think it's important to, maybe we should kind of just go through a small checklist of some of the more common conditions that you see with men's pelvic health and men's pelvic pain.
So with men's pelvic pain specifically, and disclaimer for anybody that's listening, I always say this: we're talking about men in the context of people with penises, and somebody with a penis that has a prostate anatomy from just like reproductive standpoint are not going to have the same anatomy as somebody born with a vagina and a uterus. And so when I'm talking about men, I'm talking about somebody that has a penis and a prostate. And so all of that to say, some of the more common diagnoses that I see in men in my clinic is a condition called prostatitis. I won't go down the rabbit hole of prostatitis, but essentially there's different categories of prostatitis. And the most common form of prostatitis is chronic non-bacterial prostatitis, which all that means, just like it sounds, is there's no bacteria causing inflammation in the prostate. And so for the longest time, people were getting thrown rounds and rounds and rounds of antibiotics and high-dose steroids, and nothing was happening. And it still happens to this day. Sometimes I'll get patients that have seen so many physicians and have gone on so many antibiotics and nothing's helped them. But basically, the nomenclature has been changed recently from chronic non-bacterial prostatitis to chronic pelvic pain syndrome, because they found that most of the patient's pain, while it presents as inflammation in the prostate, could actually be being created by tension through the pelvic floor musculature. And so that's, in terms of pelvic pain, that's probably the most commonly treated diagnosis that I see in my clinic, shortly followed or closely followed by testicular pain. I see a lot of people with testicular pain, and a lot of that pain, some people will think that it's their testicle that hurts, or it's their epididymis that hurts. I can see a lot of epididymitis on prescription referral forms, but the muscles of the pelvic floor, the hip flexors, the psoas, iliopsoas, and even some of the banana peel muscles that I talked about, the bulbospongiosis, they can refer pain into the testicle or the scrotum. And so a lot of people will go to the urologist, and they'll have all of these tests done and scans done, and nothing will come back. And that's usually when they end up in my door, because it's more of a muscular function causing the testicular pain. I'm trying to think. Prostatitis, like I said, is the biggest one. Testicular pain. Sometimes people will just have general pelvic pain, like the space between the testicles and the anus, or the perineal body. Some people will just have pain and tension there, and that's, I always joke with people, it's the grand central station of the pelvic floor, the perineal body, and so everything attaches into that. And so constantly, if your muscles are constantly playing a tug of war with one another, it's kind of the same as like getting a tendonitis. And so sometimes people will just have general perineal pain. There are a couple rectal dysfunctions that I treat. Proctalgia fugax is just basically, people will describe it as like a lightning bolt going up their ass, and it just like, it's this really intense, quick spasm of the posterior pelvic floor muscles, and that's a pretty common one that I see as well in men.
So I want to just hang on that prostatitis for a moment, because you mentioned that in the beginning. And, I think a lot of people don't know what the function of their prostate gland is, right? So
I would say that's a fair assessment.
Yeah. Tell us what the function of it is. Because I think people, when they hear that, they think of like an older man's condition. And I'm not quite so sure that's the message we want to send, right?
Right. No, it is absolutely not an older man's condition. And in fact, most of the patients that I see in my clinic are in their 20s and 30s, 40s even. I have a few, 50s and 60s patients, but I would say the vast majority of my patients are 20 to 40 demographic, with prostatitis anyways. And the prostate, its main function, it's a gland, and its main function is to help secrete seminal fluid and help prepare the sperm to make it from the testicles out the penis. And so they coat the prostate, sends out the seminal fluid. It coats the sperm that it travels in to help kind of neutralize the pH so that it can enter safely into whatever orifice or into wherever it's going after it leaves the scrotum. But so the prostate, when it's quote unquote inflamed or it has any sort of inflammation to it, they don't really know why it happens. In somebody that has bacterial prostatitis, it's usually from an STI or a UTI. But in somebody that doesn't have any of, their urine cultures keep coming back negative, their sperm cultures keep coming back negative, generally, even though the prostate's quote unquote inflamed, it's usually a function of the pelvic floor muscle tension that the muscles are creating. And to your point about it being an older man's condition, anyone can experience stress, but 9 times out of 10, when people come into my office and they have prostatitis, it's generally a function of some kind of stress or stressor in their life. And so that's usually why I feel like the younger population tends to present with it more frequently, because stress is inevitable in our lives, but people manage it in lots of different ways. But when you don't manage it well, it usually presents somehow in a physical manifestation. And for my patients, it presents with pelvic pain or prostatitis symptoms. But yeah, it's interesting. I would say most of my older patients, it's rare that I actually have somebody, I would say, over the age of 50 come in with prostatitis symptoms. Usually they're more, erectile dysfunction or urinary symptoms, urgency, frequency. I'm sure you've heard of BPH or benign prostatic hyperplasia. Basically, their prostate gets enlarged and it increases urinary and urgency symptoms. But it's rare that I see somebody of that age demographic actually come in with true, chronic pelvic pain syndrome or prostatitis symptoms.
The stress connection is interesting to talk about, because I think when people hear, they can identify that stress might cause, let's say, neck pain, or it might cause lower back pain. But in your patients with kind of the more general pelvic pain, where they have pain between their scrotum and their anus, are you seeing people with a lot of current stress in their life, toxic stress, post-traumatic stress? What do you think is the root cause of that?
All of the above. My spiel or general explanation for patients is that, people fall into one of two categories when they have pelvic floor dysfunction. It's usually an underactive pelvic floor or an overactive pelvic floor. And underactive, like I mentioned earlier, think of somebody who's just given birth or somebody who's perimenopausal. They just need a little bit more strengthening. But somebody with an overactive pelvic floor has a pelvic floor that's just so locked up that it never, ever relaxes. And, that can happen for a lot of different reasons. Stress, like we talked about, post-surgical, rehabilitation, somebody who has some sort of trauma or fall or history of sexual assault or abuse. Stress is such an umbrella word for a lot of different things, and a lot of different stressors can be the culprit of somebody's symptoms. I've seen people that have a history of sexual assault, even in men, that, maybe it happened in their childhood and they've been dealing with all of these pain symptoms their entire lives. Or somebody who, fell down the stairs and got their tailbone has been impacted. And so that sort of stress can cause pelvic floor dysfunction. But stress in and of itself, like, you go to your job, you hate your job, and you have a fight with your boss. Myself, I identify as somebody like that. When I am stressed or pissed or anxious, getting into pelvic floor therapy, PT, you learn a lot about yourself. And I definitely have an overactive pelvic floor, thinking about the different types of symptoms that kind of fall into that category. And like I said, when I'm stressed or pissed or anxious or mad, my pelvic floor is locked up into my throat. And, I always joke with people, think of somebody with an overactive pelvic floor. it's not funny, but it also kind of is. I call them tight asses, and those are the people that just don't ever relax. And if you don't ever relax or figure out ways to relax, those symptoms are going to, manifest likely sometimes as pelvic floor dysfunction. So yeah, that's
so tight ass is kind of a good metaphor in a way.
In a way, yeah.
But it is interesting, as clinicians, it's interesting to think about how the sympathetic nervous system has an impact on, all the organs of your pelvis, which people don't even know necessarily where their organs are in their pelvis, but to make the connection between stress and your pelvic floor is a deep connection. I'd imagine it's probably an intimate experience to have with a patient, and it's intimate for them to start to explore their own pelvic floor and pelvic health, right?
Yeah, for 1000%. I kind of in my intake spiel, after I've explained what the pelvic floor is and I've talked about its function and I've correlated it to why they're there. I always tell, kind of be real with people. I'm like, a lot of what I do in here is just help people learn how to relax. I teach people how to connect with their bodies and connect with their pelvic floor and understand what's happening and why it's happening and figure out ways to help people relax, whether that's through different breathing techniques, whether that's, different exercises or therapeutic stretches or, different hands-on techniques that I can facilitate with, dry needling or shockwave therapy, whatever it may be. The most basic watered down explanation that I give people is I just teach people and help people learn how to relax. A lot of what I do is just getting people to get in touch with their sympathetic nervous system and parasympathetic nervous system and learn how to downregulate themselves so that they can get out of these upregulated flares that they tend to get into. But yeah, it's very intimate work with people. People have to get vulnerable, and I try to create a safe space for people to do that, because I try to keep it lighthearted. Obviously, I'm serious and professional, but I try to keep it lighthearted with people. And I always kind of tell them, I'm like, we're going to become best friends by the time we're finished working together. I'm going to learn a lot about you. And hopefully, if you're honest with me, you're going to share a lot about yourself so that I can help figure out the best way to treat you. But that's getting to people's ability to just relax and figure out different coping mechanisms and, therapeutic relaxation techniques, whatever it may be. That's a lot of what I do with chronic pelvic pain syndrome.
So you started to talk about some techniques and treatment. You mentioned dry needling. I'm sure people are wondering, how dry needling comes in and where is that used and what part of the body?
Right.
Probably some visuals happening out there and how effective that can be. But I think a good place is probably start before we go into, more of those interventions is what does an evaluation look like when they come to see you as a pelvic health therapist?
Sure. I can't speak to everybody. This is kind of this is what I do with people. And I've taken a lot of different, training courses through a lot of different institutions, and I've kind of blended all of them together. But in general, my evaluations, every new patient is 90 minutes. And whenever I'm with people, usually the first half of that, honestly, I'm asking questions that people probably haven't ever been asked before, or they've never shared with anybody. They're sharing details about their very personal lives, that, who they have sex with, how they have sex, if it hurts whenever they have sex, different issues with peeing and pooping. 45 minutes of my 90-minute eval is usually just spent talking, just a lot of history taking, getting more information about them. And then usually by the time we're done talking, I already have a pretty good sense of what's going on. Most of the time, like I said, I don't know if it's because of the marketing that I've done and the referral networks that I've made, but most of the people that come in to see me have some variation of an overactive pelvic floor. So I already kind of have an idea of what's going on. But when we move into the actual exam component, that I always have people do a movement assessment. There are various movement assessments out there, just quick mobility screens. I have them do 6 or 7 different movements just so I can see kind of where functionally they're deficit. And then I'll move into my orthopedic exam, where generally I tailor it to what they're coming in for, but kind of, again, blanket kind of coverage. I look at, strength of the hip muscles, hip flexors, glutes, glute med, adductors. I check, strength or range of motion and flexibility of those same muscle groups. I'll palpate I always joke with people that when I'm doing my palpation, or a lot of pelvic floor therapy is kind of my specialty, is everything above the knees and below the ribs. And so when I'm doing my palpation exam, I tell them, if it's cool with you, I'm going to be feeling for these different muscle groups and just kind of see from your rib cage down to your knees if anything is tight, tender, painful, stiff, restricted. And then based on that, if I feel like it's necessary or indicated, we'll move into the pelvic exam. And with the pelvic exam, the first thing that I do is just a general kind of breathing observation. We haven't talked about it, but I almost went down this rabbit hole when we were talking about relaxation techniques, but I'll save it for now and just kind of tiptoe around it. The pelvic floor and the diaphragm are best friends. And so a lot of what I do, in talking about helping people relax, is learn how to people kind of sync up their breathing for the most optimal pelvic floor relaxation. And so I have them for the pelvic exam, just lay on the table and I'm just having them breathe. And patients are always like, so you just want me to lay here and breathe? And I'm like, yes, I do, because I'm assessing what your pelvic floor is doing in response in response to you breathing. And so I'll have them just lay there. They're usually unclothed if they're cool with it. Having them lay in a butterfly position, and I'm just observing what their pelvic floor, their perineum, is doing in response to them just breathing. And then based on that, based on what I find, we usually go into how to make that appropriate contract, relax, that appropriate piston mechanism happen. And then we'll do an external palpation exam. I always say, imagine a clock is on your pelvic floor, your perineum. 12 o'clock's the pubic bone, 6 o'clock's the tailbone. I'm just going to go around a clock and feel for different muscles around this clock to see if anything is tender, tight, painful. Another part of my spiel is that, healthy tissue shouldn't hurt. It shouldn't be painful. And so if I'm pressing or poking on anything and it causes you pain or recreates your type of pain, it's an indicator of what may be impacted or implicated in your symptoms. And so generally I'll stop at the external palpation exam, unless I feel like it's indicated on that first visit for them to get an internal pelvic floor exam to really understand what's going on with their symptoms. Sometimes I'll get through all of that and I'll find deficits, or I'll find restrictions, or I'll find muscles that may be impacted. But certain diagnoses, like, usually testicular pain, I'll stop at the external palpation exam. But, prostatitis or erectile dysfunction, or especially proctalgia fugax, usually I'll do an internal exam. But with the internal exam, we're reviewing that breathing, that pelvic floor relaxation, mobility that they hopefully will get once we go through the breathing assessment. And then usually I'm checking internal palpation, checking for the pelvic floor. Again, I equate it to a clock, or I relate it to a clock rather. 12 o'clock is pubic bone, 6 o'clock's tailbone. I go around right to left all around the clock and try to find muscles inside that may be recreating their pain or maybe problematic or restricted. And then after that, we do any other kind of general assessment or physical therapy assessment and plan. I talk about what I found, tell them what I want them to work on until I can see them again, and tell them what I would like to do the next time I see them, whether that's exercise or hands-on stuff, or, revisiting the breathing and relaxation stuff. I try to get through all of that in 90 minutes. I don't always, it's 90 minutes sounds like a long time, but I don't always get through everything, especially if somebody has a very extensive, history or intake that there are a lot of details they feel like they want to share. So that's usually the first visit. The second and subsequent visits are usually when we get more into like actual treatment stuff, different hands-on modalities or different exercise, prescriptions. But the first visit is usually a lot of just examination stuff.
Yeah, I think that's a really great description. And I also think it helps people to know that if they're second thinking about coming to pelvic health, it's good to know that there's a lot that can be done just by having obviously your history, going through the history, and some basic movement exam type features to it, that it doesn't necessarily have to involve an internal examination on the first visit. It may later on, but there are many steps that we can take before to help you with the pain that you're experiencing.
Right. And that's honestly, when patients finally do get to me, there's a lot that patients, in terms of their thought processes, they go through before they even reach out to me.
Yeah, I was going to ask you about that actually, because if someone's coming to see an OBGYN, for example, they pretty much know that there's going to be an internal exam at some point. But if you're coming to a pelvic health physical therapist, there's not always that knowledge base that's there.
There's not. And I've really tried to work. I have a group of, physicians in the city that I work very closely with. And I've been very intentional about the physicians that I've, built those connections with. And I've done a lot of education about what I do and how I do it. And so, but you're right though, if somebody's just given birth, they go see their OBGYN and they're like, I want to go see a pelvic PT. They may already know that there may be an internal exam, but Joe Schmo on the street, he has, prostatitis pain that he is too embarrassed to talk to his primary care about. He finally breaks down or he's probably doing all of his Googling at home, reading all of the terrible things on WebMD about what could be going on, decides to go see a urologist, and his urologist may or may not know about pelvic floor therapy. If he does know about pelvic floor therapy, we'll probably refer them, but also have no idea about what it all entails. So most of the time patients come in and they're like, what am I doing here? What are we doing here? So I try to do, assuming whenever a patient reaches out to me, I always assume the worst. I assume that they have no idea about anything that I do. And because 9.9 times out of 10, they don't. They have either read about pelvic floor therapy online, or they've been referred by a physician that told them that they needed therapy. And so I try to do a lot of education before patients even get to the clinic so that they know what to expect and what might happen. My evals are 90 minutes because I really wanted to make sure that I allotted enough time to talk to people, because a lot of people, like I said, they're telling somebody in the medical profession for the first time about a lot of these symptoms that they've probably never been asked before. And so I always make a blanket disclaimer that depending after the conversation that we have, that'll give me a better idea of whether or not I think an internal exam will be beneficial. Mm-hmm. And if it is beneficial, or if I do think it would be beneficial, we absolutely do not have to do that today. I realize that this was just kind of sprung on you, and you probably weren't expecting to come to a visit today, getting a finger up your butt. But if at some point I think it'll be beneficial, we can explore that in a session or two. There's lots of other things, like you said, that I can do and we can do together to kind of come up with a plan before we even talk about internal exams.
Yeah, really well said. And I think that's important information for people to have. And as you mentioned, some physicians aren't aware of the services that a pelvic health therapist can provide for their patients, whether they're male or female. Can we talk about erectile dysfunction for a moment?
Yeah, absolutely.
I think people would like to hear your perspective on treating erectile dysfunction, or things they can do to prevent erectile dysfunction instead of relying on medication or being improperly diagnosed at times, because it's another sensitive area for men to have a discussion around.
It is a sensitive discussion. And I am going to, when we're talking about ED, it depends on how patient, and my least favorite phrase in PT school was "it depends." And when we're talking about ED, it just it depends on how they're presenting. If they're a young guy, 20 years old, coming in with issues, getting an erection, my assessment for him is going to be very different than someone who is 45, 50, 60 years old who has erectile dysfunction. They might fall into the same category, they might not. And in order to know that is one diagnosis that an internal exam would be beneficial for. But from a therapeutic standpoint, just basic, I'm all about analogies, because I feel like when I'm talking to patients, it really helps to people to conceptualize what might be going on. But when we're talking about erectile dysfunction, the best way that I explain it to people, or have found to make it make sense for people, and I'm going to have you do this with me. I just want you to squeeze your fist as hard as you can. Just squeeze it for a couple of seconds. Squeeze. And if somebody's listening to this, also do the same. And then I want you to just let that fist go and take a look at your palm. All of the blood that's rushing back into your hand right now, That same principle, that vascularity principle, can be applied to the pelvic floor. And we talked about that clenched fist pelvic floor, that overactive pelvic floor. If people are constantly staying in that tight ass position, if they're not relaxing enough of the pelvic floor to even allow blood flow into the pelvic floor or the penis, getting erection is going to be really hard, really difficult, I should say. Really difficult. And so if somebody, like I said, the 20, 25, 30-year-olds coming in and they're like, listen, man, like I can't get it up for anything. Those people are going to be the people that I'm looking at, how well can you relax the pelvic floor? Do you have that mobility in the pelvic floor muscles to, allow blood in? Always where I start with people. If somebody's coming in and they've seen their urologist, they're on PDE5 inhibitors or Viagra, Cialis, and those drugs are working or they may not work very well anymore. If, like I said, if they're in the older demographic, usually I need to say that erectile dysfunction from a vascular component is one of the first indicators of a heart disease issue. And so if somebody's coming to see me for the first time and their main complaint is ED and they haven't seen a primary care or even, their urologist or a cardiologist, I'm always referring them to go get their heart checked because, I had a patient or currently have a patient who I'm treating for ED. He started having signs of erectile dysfunction 2 years before he had a heart attack and came out of nowhere, seemingly healthy, seemingly fit, didn't have any overt signs of heart disease, but, correlation doesn't necessarily mean causation, but you have to wonder. And, it's one of I forget what year it was kind of put out there, maybe last year or 2 years ago, but erectile dysfunction should be considered as one of the, not a vital sign, but kind of like a vital sign, like how are your erections? Because it's one of the first indicators that's been published and studied of being correlated with some kind of heart dysfunction disease. So like I said, if it's somewhere, if they're an older demographic, if that's all they're coming in for, if they don't have any pelvic pain symptoms or no testicular pain or anything else, urinary symptoms, if it's just ED, I'm going to make sure that I have a physician on my treatment team to make sure that they've had their heart checked. Conversely, if that is their main symptom, then I'm also looking at how strong their pelvic floor is, which you're going to be like, but wait, if it's overactive, why? And we're working on relaxation, why do they need to make it even stronger? And, this is a great thought, but if I've done their internal exam and I've assessed them and I've checked everything that I mentioned before, and, if people are listening, if they're physical therapists, the 0 to 5 grading scale, if I'm doing a pelvic floor exam and I give them a 2+, okay, I'm going to give them some strengthening exercises to help kind of bulk up the pelvic floor tissue, because the main jobs of those banana peel muscles that I talked about, one of them is ejaculation and one of them is erections. From a muscular component, they help those functions happen. And so if somebody presents with an underactive pelvic floor and they just need a little bit more strengthening, then sure, I'll give them some strengthening exercises. I'll help them with their general kind of hip and pelvic strengthening stability. But if it's going back to my 20-year-old younger guy who's chronically in a state of overactive tension, I do his internal exam and maybe he has a 3 out of 5 pelvic floor strength. I'm still not going to give him strengthening exercises, because if you've ever, I'm sure you have, but you think of something that's strong or overactive that doesn't have that full range of motion to do a contraction, inherently it's also weak, but for a different purpose. Right. And so for that patient, I'm still not giving him strengthening stuff. He's going to be working on relaxation and more flexibility stuff until he gets that full range of motion. And then we might incorporate pelvic floor strengthening stuff. But in terms of erectile dysfunction in general, people, you go on Google, you go on Reddit, and you get down these rabbit holes, and you think the worst. And a lot of my patients, they come in and they're like, I don't want to be on medications. I want my erections back to when I was 20 years old again. And I physical therapy isn't witchcraft. Like I don't have a magic wand that I can wave and magically get you an erection. I'm going to do everything that I can from a physical standpoint to get you to where you should be, your most optimal state to get an erection. But if it's a function of age, if it's a function of hormones, if it's a function of past medical history, heart disease, like while I can help you with that, get more physically fit, which your erection may be a byproduct of that. Your erection strength might be a byproduct of getting you physically fit. The medical side of things, if it is a true medical issue, unfortunately, physical therapy is, I'm not going to say it's not beneficial because I feel like everyone can benefit from physical therapy, but it may not be the most optimal route for somebody with, an older demographic that has a bunch of past medical history stuff. My skills are going to be limited at what I can provide. The caveat to that, though, there's a new technology out on the market right now. I shouldn't say new, it's been around forever, but shockwave therapy I mentioned earlier is a new modality in the terms of pelvic health function and being used for erectile dysfunction. It's, again, analogies, watered down explanations. Shockwave helps to create new vascular supplies to the tissues that you're being treated. And so in the urology realm, a lot of urology physicians are using shockwave as an alternative to medications that people may not want to take or may not be able to take. I have some patients that are like, I can't take Viagra because it gives me this intense migraine, or Cialis at its most potent dose doesn't do a whole lot. And there are a lot of reasons as to why that may be. But shockwave therapy is an alternative treatment method for erectile dysfunction that I have in the clinic that people benefit from. The people that are going to respond, I feel this is important to say, because if listeners out there are going to be researching shockwave therapy, there's lots of different types of shockwave therapy out there, and it may not necessarily be true shockwave therapy depending on the device that the clinic or clinician has. And I don't do any marketing for shockwave. I'm not an ED clinic. That's not what I want to treat. But there are clinics like that out there that have quote unquote shockwave devices that are marketing themselves as ED clinics and just accepting anybody that wants to come. There's a research study that just came out in 2022 about shockwave therapy, and it's most beneficial for patients who either don't need any sort of PDE5 inhibitor, and so Viagra or Cialis, they don't need that and can still get an erection, but it's just kind of weak, they're not super satisfied with it, shockwave therapy would be beneficial for them. Or patients who still respond to those medications but may not respond all the time, or still may not have the best erection quality that they would like, shockwave will be beneficial for them. The people that shockwave won't be beneficial for are the people that cannot get an erection with any sort of medication, or even, I talk about Viagra and Cialis, but there's other substances or medications like Bimex or Trimix that are just a punch in the face of nitrous oxide to help get patients to get an erection. And if you're not responding to that, shockwave isn't going to do anything for you. And so the milder to slightly moderate cases of ED are the people who, if they come into my clinic and they're coming in with ED, those are the people that I'm going to treat. That I shouldn't say that I'll treat, that I will give them the education of whether or not to pursue with treatment. And same thing with somebody with, severe ED. I'm going to give them the education. I'm going to tell them, listen, studies show that this probably isn't going to do much for you, and leave it up to them of whether or not they want to go through with therapy. At the end of the day, like, I'm not trying to steal people's money. And if they want to receive treatment, I'm not going to tell them that I won't do it, but I will make sure that they are informed that they are likely not going to benefit from it. Some people just are kind of grasping at straws and want something other than a penile implant or a penis pump for the rest of their lives. Who am I to take that away from them? But if, depending on the severity of the ED, shockwave, in my experience, hasn't been super beneficial.
Yeah, all really good, valid points. I mean, as you said, if you go onto the internet and look at the world of erectile dysfunction and potential treatments, there's all sorts of promises, pills and potions out there. And it takes a licensed health professional like you to differentially diagnose and figure out where it's coming from and how it can be treated? Do you just need one form of treatment, or maybe you need a couple of different treatments to to help treat that and to manage it as best as possible? You've been very clear about so many aspects of male pelvic health, which I think is really great. It's been a pleasure speaking with you, but I wonder if you could just kind of, as we kind of wrap up, give men and women as well, because this is a topic of interest to women also, how can they keep their pelvic floor as healthy as possible with just some kind of, basic lifestyle interventions and ways to cope as you get older with your health in general?
I get that question a lot. And honestly, my best advice for people is to find ways to manage your stress, whatever that looks like for you. Some people, enjoy hiking. Some people enjoy, walking. Some people enjoy going to yoga. Some people meditate. There's lots of different ways for people to manage your stress. You just kind of have to figure out what works best for you. And because most of my patients fall into that overactive category, I'm constantly trying to be creative with patients to figure out what they enjoy and to help them figure out ways to relax and to reduce stress and maintain their pelvic health. I really, really love yoga for people. Obviously you're not going to like a core power yoga and doing their hot yoga class with like jamming to Beyonce, but like the slow, controlled, static kind of, or even dynamic stretch positions are a great way to optimize pelvic health, because just like every other type of physical therapy, motion is the lotion, movement is medicine. And if people are moving, people aren't staying static. If people are trying to stretch and be active, ultimately that is going to be the best form, pelvic health than not doing anything. And so people always tell me, or I always hear on various ways, like, so I shouldn't be doing 1,000 Kegels a day, which is like, absolutely not. Please do not do that. Or like on TikTok or Instagram, there are these trends where you do Kegels to like the beat based on whatever song it is. And just like, why are we teaching people to do this? I mean, it's going to be great for my business, but like terrible for all these people out there. So like, if you're just like constantly doing Kegels all day long, please stop. That's not going to end well for you. And you're probably going to need a pelvic PT like myself. So yeah, I mean, just, trying to figure out ways to manage stress. I probably, whatever that looks like is priority number one. And two, figure out ways to move your body that are going to be productive, that promote some sort of movement and flexibility through the pelvis. All of those, and people with penises, there's 12, and people with vaginas, there's 14. Those muscles attached all over the hips and pelvis and low back. And so trying to get more mobility through those areas is going to be the best way to maintain your pelvic health than, doing a million Kegels every day.
So sitting for long periods of time under intense stress is probably the worst thing for your pelvic floor.
Probably not great. That's
and your penis for that matter.
Yeah, and your penis for that matter. Yeah. So many of my patients have, COVID didn't do anybody any favors, but people who used to get up and travel and move around all day at work and walk between different offices are now confined to their couch or their dining room table or wherever they may be, and they're just sitting for 8 hours a day. Like COVID did wreaked havoc on a lot of different things, but it especially people that didn't know how to manage their stress and then were static for long periods of time did not bode well for their pelvic health. Mm-hmm. So yeah, sitting for a long time and being super stressed, probably not going to end well for you.
Lance, it's been great speaking with you today. I know everyone's going to really appreciate this episode and all the information you shared. How can people learn more about you and follow your work?
Sure. Well, I'm based out of Atlanta, Georgia. My website is flexptatl.com. If people want to learn more about my clinic and learn more about me or schedule a session with me, I'd love that. If I do a lot of education online, mostly through social media, Instagram and TikTok are my go-tos. I also have a YouTube channel, but I don't post much to it. All of those are, the handle is Lance in your pants. So any of those social medias, or people can email me directly if you listen to the podcast and want to chat with me directly. My email address is lance@flexptatl.com.
Great. So the website is flexptatl.com. You can check him out, Lance in Your Pants, on Instagram. And you mentioned online work. Do you work with clients online?
I do. I do virtual, I call it coaching. If you're a physical therapist, you know that we have, state practice acts, then physical therapy can't cross state lines, but coaching can. And so I do coaching with people virtually if people want to work with me and they think that I'm the best fit for what they've got going on. I have a guy right now in Ireland. I have another guy in Canada. I've worked with a guy in Australia once, in Qatar. That was kind of cool. But yeah, I work with people virtually.
Excellent. So all those links will be on the show notes at the integrativePainScienceInstitute.com over at this podcast episode. Make sure to share this episode with your friends and family on Facebook, LinkedIn, Twitter, wherever anyone's talking about male pelvic health or pelvic health physical therapy. I want to thank Lance for being here this week, and we'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrativepainscienceinstitute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.